Well, welcome everyone. I'm Casey Peluso from Parkinson Foundation, Western Pennsylvania, and joined by Christine Haythorne, our CEO and Executive Director, as well as David Von Hofen, Program Director. Emily Rousseau is somewhere in the background next door doing some important other work. Thank you for her support as well. And thank you so much, Dr. Miri, for joining us today and providing your time and expertise. And I'll hand it over to Dr. Miri in one moment. First off, I'd just like to ask everyone to please mute themselves. And then at the end, there will be some time for questions in which you can unmute. And also, if you have any questions during, you're welcome to use the chat function. But Dr. Miri will take questions in the end. And I'd like to now introduce Dr. Shahnaz Miri. Dr. Miri is a board-certified neurologist, neuro-ophthalmologist with a fellowship training in movement disorders. She attended Tehran University in Iran, where she is from, and obtained her medical degree. She also has an MBA degree from Western Governors University in Utah. Dr. Miri completed her neurology residency at MedStar Georgetown University Hospital. She also completed a movement disorders fellowship at MedStar Georgetown University Hospital and a neuro-ophthalmology fellowship at Bascom Palmer Eye Institute at the University of Miami. And she is now joining the Wilmer Eye Institute at Johns Hopkins University as an assistant professor of neuro-ophthalmology. Her research interests include vision disorders and ocular biomarkers in neurodegenerative disorders, including Alzheimer's disease and Parkinson's. So Dr. Miri is well respected in her field, and we're honored to have her present today on visual impairment in Parkinson's disease. Now, without further ado, I'll hand it over to Dr. Miri, and thank you again.
Thank you so much, Casey, for the introduction, and hi to everyone. Thank you so much for having me, and it's a pleasure to have this presentation today. I'm just sharing my screen with you all. So the topic of this talk is visual disturbances in Parkinson's disease. I have no financial disclosure for this talk, and let me see if I can move to the next slide. Okay, so no financial disclosure. And I go over the objectives for this talk. First, this talk will introduce some of the most common eye problem, vision problem in Parkinson's disease patients. And also this talk aims to just increase awareness about this eye problem in Parkinson's patients, and also to just initiate like evaluation and management to improve safety, independence, and quality of life with taking care of these vision problems. So as all of us know, Parkinson's disease is a movement disorder, the second most common neurodegenerative disorder in the world. And the main symptoms of Parkinson's disease are motor symptoms, movement problems, including tremor, rigidity, slowness of movement, and a gait problem, walking problem, postural instability. But Parkinson has a lot of non-motor symptoms, symptoms like anxiety, depression, constipation, fatigue, lightheadedness, orthostatic hypotension, loss of sense of smell, memory problem, sleep problem, urinary problem, and also vision problem. So vision problems are reported up to 87% of patients with Parkinson's disease. Also, a specific vision problem that is visual hallucination is reported in up to 37% of Parkinson patients. So this is very important, but there is not much known about this area of vision problem in Parkinson. So here we are going to go over vision problem that Parkinson patient might experience. This includes two different categories. One is age-related vision problem that can happen in anyone after a certain age, like say 40, 50. So it also happens in Parkinson patient. Also, vision problem that are specifically related to Parkinson, or to say more common in Parkinson patient than other, same age people. So let's go over first age-related eye issues. So the most common age-related eye issue is presbyopia. That is difficulty focusing, or called a blurred vision when you're reading, either in close or in distance. And it happens in everyone after the age of 40. And so as you can see, this is an eyeball, and the light goes into the eye from the front of the eye to the back of the eye. And there in the back of the eye, the vision, the image will form, and the nerves in the back of the eye will send that information to the brain. But in after some certain age, this light, because of the change in the shape of the eye, and the front of the eye, usually the light doesn't shape the image right in the back of the eye. So to correct that, there is a lens or some eyeglasses needed to just correct that vision and the formation of that vision in the back of the eye. So that's why people after, say, the age of 40, 50, they will have blurred vision, and they will need some just eyeglasses to be able to read properly. And sometimes for distance, they will need that. But again, that's a just common problem in anyone. But in Parkinson patients, usually some people, if they don't have routine eye exam, that will be missed. And there is a simple solution for that, which is eyeglasses. And better to just take care of that, because people with Parkinson usually may not complain about that, and no one will take care of that if they don't complain. So better to just be aware, and if you see blurred when you're reading, or if you see blurry when you look at distance, maybe you just need simple eyeglasses to take care of that. Then other problem is cataract. Cataract is if again this is the front of the eye, and this is the lens that will condense the light to the back of the eye. So sometimes after, again, certain age, like say 40, or I would say 50, 60, this lens will become cloudy. And then, sometimes people might have a mild degree of cataract, which is fine. But if it is really severely cloudy, then that needs to be replaced, and with a artificial lens, and that will take care of the vision, because if it is cloudy, people will not see as well. And again, that's another common problem in anyone, not specifically in Parkinson, but again, with a routine eye exam, you can find out if that's your problem or not. Other than that, glaucoma, that you might have heard of it, is another common problem. And that is just because of the increase in the pressure inside the eye, that in long term can cause nerve damage. This is the optic nerve, that because of the high pressure in the eye can be damaged, and the vision can be affected. So again, a routine eye exam, in a routine eye exam, they check the eye pressure and they will make sure that is not high. And if it is high, there is treatment for that. There is eye drop that can prevent future damage to the optic nerve. So again, a routine eye exam can take care of that. Next problem is macular degeneration. So in the back of the eye, in the retina, the center of the vision, sometimes there are some degenerative changes, and that will cause, here you can see the image of the back of the eye. When we look inside your eye, we see this area, and in people with macular degeneration, there is a lesion in the back of the eye that it just happens gradually and might get worse. But again, in a routine eye exam, we can catch that early, and we can monitor that, and we can like if something if getting worse, or there is some cyst or anything in the back of the eye, with eye drops and some other treatment that can be taken care of. But not to say that this is more common in Parkinson. No, it's just like other general population might have also experienced this issue. That's a retinal issue. And again, that's something to be aware of, to have a routine eye exam to catch it early. And if it happens, they can monitor, the retina specialist can monitor it to save the vision in people. So that's another problem. And again, like we said, routine eye exam with ophthalmologist or optometrist can take care of that. Now, eye problem in Parkinson patient. What are the most common eye problem in Parkinson patient? The number one is dry eye. So dry eye is reported from like 80% of Parkinson patient up to all the way 60-70% of Parkinson patient. They have decreased blink rate, so they don't blink as much, and that will, in addition to that, they will have the lacrimal gland and the meibomian gland dysfunction that will result in reduction of tear in front of your eye, and that will cause dry eye. Other problem, we'll go over the detail of that. The other problem is eye movement abnormality. That is very common in Parkinson patient. Diplopia or double vision has been reported in up to 10 to 38% of patients with Parkinson's disease. Other vision problems include depth perception problem, impaired color vision and contrast sensitivity, and also visual hallucinations. So we are going to go over all that. So dry eye symptoms, when someone has dry eye, they might experience soreness in front of the eye, red eye, watery eye, and or just pain, burning sensation, or itchiness in the eye. And again, that's a common problem. In general population, it might happen up to 3% of people, but in Parkinson's disease, as you can see, is like a lot more common. And in Parkinson patient, not only because you can see here, like the lacrimal gland is here, like outer side of the eye in the upper part. And, that lacrimal gland doesn't secrete enough tear in Parkinson patients. So tear is a lubricant in the surface of your eye. So if there is not much tear, then there will be some inflammation, some dryness of the eye. Other than that, Parkinson patients also have a decreased blink rate. So the rate of blinking is less compared to other people. So that will also, because with blinking, you will distribute the tear in the surface of the eye, but if you do not blink as much, then your eye just stays dry. So that will add on to the eye problem, and that will cause irritation of the eye. And also at the tip of the eyelids, there are some small glands, and again, sometimes they might be clogged, and that will cause also additional inflammation and dryness, like in the eyelids and the surface of the eye. And like you can see here, that can cause irritation like this, or inflammation of the eyelid that we call blepharitis. And some other studies reported up to 60% of people with Parkinson's disease might experience that. So that's a very common problem. And now, what does it do to your vision? It will cause blurry vision intermittently because it is dry, the surface of the eye. Then you might see blurry, you might see double, you might see cloudy, and you blink a few times, then it gets clear. So that will say that your eye is dry, probably. And you might say, get blurred vision when you watch the TV or when you drive. So that's all may come from dry eye that should be taken care of. Like we said, burning, itching, tearing, gritty feeling, some discharges from your eye, redness, blurred vision, again, fluctuation with the vision. And those are the most common symptoms of dry eye. So not only Parkinson can cause dry eye, there are other problems. For example, if someone has thyroid problem, then dry eye is common in those people with thyroid problem. So, or say eyelid inflammation, someone if they have an inflammatory disorders like Sjogren, some people may be like with rheumatoid arthritis or lupus, they might have some inflammation of the eye or eyelids. Some sort of medication can cause dryness of the eye. There are, or chemical exposure, injury to the eye, those all can cause dry eyes. So I'm telling you this just to make sure that we are not missing anything else and not just blaming this eye problem only because of Parkinson. Like you can see this long list, there are a number of different conditions that can cause dry eye. So it is important to make sure that your primary care doctor, optometrist, or ophthalmologist are evaluating other reasons as well, not just blaming this dry eye on Parkinson. Just to make sure they check your thyroid and other problems, just make sure there's no other reason for this dry eye. And then how to treat dry eyes. So using artificial tears will help significantly. Artificial tears, you can get it over the counter from the pharmacy and use it regularly, like 3 to 5 times per day as needed in both eyes, just to keep your eyes, wet. And also sometimes if with just artificial tears, you cannot improve that. There are gels or ointments that you can use at bedtime. And again, those are also over the counter. And just putting those like inside your eyes, and also using warm compresses or some eyelid scrubs that can help to reduce the inflammation of the eyelid and improve dry eyes. If these are not helpful, physicians, ophthalmologists, optometrists can prescribe you some other eye drops, the prescription eye drops that can significantly help with the eye inflammation and the dryness. Again, better to see an optometrist, an ophthalmologist first to make sure there is no other reason for your dry eyes. And if that's the case, and if this like conservative management over-the-counter drops doesn't help, then they will prescribe you some other medication that can help. So that was the topic of dry eyes. There is another common problem in Parkinson patients, that's eyelid twitching or blepharospasm. So that's uncontrolled squeezing or twitching of the eyelid. Sometimes dry eye itself, because of the irritation it causes, can lead to some like more twitching of the eyelids. But sometimes separately, this is a separate condition that is called blepharospasm, and that is because of the spasm of this uh, muscles around your eye and eyelids. That's a sort of kind of dystonia in the eyelid muscle. And how do we treat that? That's first of all, we should make sure there is no other secondary causes like dry eyes that can do that. And for example, if treatment of dry eye doesn't help with that, then botulinum toxin treatment and botulinum toxin injection to these locations will relax the eye muscle and then will reduce that twitching and spasm around the eye. So who does that? Injections or evaluation of that? A movement disorder specialist does that, and also a neuro-ophthalmologist does those injections. So you can ask always your movement disorder doctor about that. Next problem, next common problem in Parkinson is double vision. So it happens, reported in the literature, in between 10 to 38% of patients with Parkinson that they might experience double vision, and is a really disabling visual problem, and it has a lot of different reasons that we will go over. So the reasons for double visions are different. One main reason can be just motor fluctuation, like the same way when you're taking carbidopa, levodopa, and after that your motor symptoms improve, like your muscle stiffness improves, and then say when you're wearing off and you get a stiff muscle in your arms or legs or neck, the same way the muscles around your eye might get stiff when you're wearing off of carbidopa levodopa, and that will cause ocular misalignment, and we'll go over that in the next slide. And that by itself can cause intermittent double vision. Sometimes there is a just fixed ocular misalignment, including convergence, insufficiency, or hypertropia. We're going to go over it. And sometimes there is just a visual processing problem in Parkinson that can cause double vision. And sometimes just dry eye by itself can cause double vision. And then we'll go over that in detail. So in double vision assessment, first of all, history is very important, is the key, that what is causing double vision and where is this double vision comes from. So the main key, the key question here is the double vision always there? Is it constant, or is it going away when you cover one eye? We want to make sure if you see double when you look straight with both eyes, or for example, when you cover one eye, is it still double or is now like normal? And if you only see double with both eyes, then we call it binocular diplopia, or just diplopia that comes from both eyes. And sometimes it can be just seeing double only with one eye. And for example, when you look with one eye, you see double, but with the other eye, you don't see double. So that has like different reasons, just separate reasons that we'll go over. For example, just refractive problem, astigmatism in one eye, or corneal problem, or the retina problem in just one eye can cause that, or just tear film abnormality in one eye can cause just one eye double vision. But in Parkinson patient, usually it's just with both eyes. When you cover one eye, the double vision goes away. Only with both eyes you see double. It's more common. And when we go over binocular or double vision with both eyes, there are other questions that come up, including if you look straight, and for example, there is one object in front of you, do you see that object? When you see that object double, is that double side by side, or is that double on top of each other, or is it kind of diagonal? You see it like diagonal. So that will tell us more information about where this is coming from. And other than that, we'll take a look at like the head posture. Some people might have a head tilt, and with the head tilt, the double vision goes away. And some people might have history of strabismus or ocular misalignment from childhood, and that can get worse, after several years, and especially if they have Parkinson, that might get worse. Also, it is important to see if the onset of double vision is that like just sudden onset out of nowhere, or is that very gradual, and or is that like constant all the time, or is that just intermittent, comes and goes? What time of the day does it start? Some people might experience that like when they're fatigued or when they're tired toward the end of the day. These all questions in the history, when a doctor asks you all these questions, will help to just sort out where is this double vision coming from. And so in Parkinson's disease patient, mainly, like we said, sometimes it's just because of the stiffness of the eye muscles that they experience this, and after taking levodopa, they see less double, or they do not see double anymore. And sometimes it's just double vision in close, when they're reading. And again, after examination, it might be just from convergence insufficiency, which is the eye cannot come like together to look at the close, but at distance they're fine. So that is called convergence insufficiency, that the eye cannot convert to see something up close. Then there are some other, just misalignment of the eye that can, or orbit that can cause double vision in Parkinson patient. Or sometimes, there are central problems like, for example, not that common in Parkinson patient, but a stroke, a small stroke of the nerve can cause double vision, but that is constant. It's not just fluctuating. It's a constant double vision. And we see that in patients who have diabetes or high blood pressure, that they might have a smaller stroke of the nerve, and they might have experienced one of these like cranial nerve palsies that cause like just some sort of constant double vision. In those cases, they should definitely, if it's a sudden onset, they should definitely go to the emergency room to just take care of that. But again, that's not that common in Parkinson patient. So usually between all the reasons that can cause double vision in Parkinson patient, like we said, is mostly intermittent and mostly just because of convergence insufficiency. Hypertropia is just one eye. The alignment of the eye, one eye is a little bit higher than the other eye. Again, is just related to the orbital misalignment. And like we said, in less than 10% is just central due to other reason in the brain. So what is convergence insufficiency? We were just talking here. In normal situation, when you're reading, both eyes should a little bit come inside to just focus together to just be able to read the text in front of you. But in Parkinson patient, both eyes do not come together at the same angle. So one eye might come a little bit less, the other eye might come in a little bit more, and that's why you may be seeing a little bit double. And in those cases, after examination, after we confirm that this is a problem you're experiencing, then giving you a prism glasses can take care of that. So with prism, we will correct that inability of the other eye to just come and work with the another eye, and we'll take care of that. And with prism, you will see much better. Um, and yeah, this is the way that prism works. Is a like kind of piece of glass that will convert the light that goes inside to the eye with another angle to match the other eye. Then impaired depth perception is another problem with Parkinson patient, and again that is due to ocular misalignment. Also, sometimes visual processing problem can also do that, and and it can be just from the brain that people with Parkinson cannot estimate the depth of the, like when they reach out to something and they cannot catch, or when they are passing from somewhere, or when they go down a stair, they may not they will have difficulty estimating the depth of the steps, or um, and that can also, like there is a smaller study that showed that people who have gate freezing, actually they have also depth perception problem. So there might be a correlation between that, the depth perception problem and freezing of gate. But there is not much data about this topic. We just know that that's very common in Parkinson patient, and there might be different reasons. And again, the simplest way is to have an eye exam and just to see if there is an ocular misalignment that can be corrected with prism, and that can improve that depth perception or not. Um, so there is another problem that is called contrast sensitivity impairment, and that is the ability to differentiate object when it is dark, or there is low in a low light condition. And again, this contrast sensitivity is reduced in patients with Parkinson, and they will have difficulty when they are driving at night, or when they are reading, or when it is low light. Uh, they will have difficulty getting around at home or going down the stairs. And and there are studies that they show that this problem may even be one of the first symptoms in patients with Parkinson's disease, even way before they have typical motor problem, like difficulty walking, or tremor, or stiffness. Um, and like here you can see that it might happen in 18 to 50% of patients with Parkinson's disease. And another problem is impaired color vision discrimination. So we have, if you had eye exam, probably you have done this test, and that's just measures the color discrimination. And some patients with Parkinson, especially patients with Lewy body dementia, or those with visual hallucination, they have a lot of difficulty with discriminating colors. And some people may not be even aware of this problem, but in an eye exam, they will notice that. And some part of that comes from just the retina, the back of the eye, the processing, the visual information processing can be a little bit impaired because of the lack of dopamine in the back of the eye, because dopamine also exists in the retina. In some of the retinal cells, retinal neurons work with dopamine, and lack of dopamine will slow down these neurons, and this color vision and even contrast sensitivity will be reduced. Like all the processing of the visual information will be slower, and that will cause this problem. And this is again kind of under investigation and under research, but it has been shown that um, patients who have memory problem and Parkinson experience this color vision problem more. And specifically Lewy body dementia patients, most of them have this color vision problem. So they are using this maybe as a biomarker or just a marker of differentiating people who have or who will develop memory problem in the future using this color vision test. So, like I said, in the back of the eye, this is what we see when we look at your eye. This area is your optic nerve, and this is macula, the center of vision. When the light goes in, goes here, and the visual information from here go to the optic nerve, and from the optic nerve to the brain. Um, and in the left side is an image, optical coherence tomography, that we take when you come to eye exam sometimes to just see the retina. And this is a cross section of your retina. And this is a normal 50-year-old person, and this is how the retina should look like. And this is a sample of retinal image in patients with Parkinson. And as you can see, we can detect that there is a little bit thinning. You know, in normal aging, we will see thinning, like in a, say, comparing a 50-year-old to an 80-year-old, there will be definitely a little bit reduction of the cells of the retina, and the thickness of the retina is reduced. But also, if you consider same age Parkinson patient and a healthy person, you will see again that difference. And this, how does how does this affect the vision? You know, it's still under investigation, and this is not a just a routine test to do for Parkinson patient, but this is the goal, to maybe do more research on this and to do this as a future, you know, kind of routine eye examination again in the future. But this is what we can see now. um, this by itself is not a problem, but in this kind of image, we can also detect some other pathology. Like I said, macular degeneration, we can detect that. This right side image doesn't have macular degeneration, but again, if some patients with Parkinson's disease are suspected to have that, we can detect that with this retinal scan, which just takes just like less than 2-3 minutes to just get this image done. And this I just already explained. And so other than that, we have another common symptoms in Parkinson patient, visual hallucinations. So sometimes just Parkinson medication can cause that. If there is too much dopamine, if some people take, like, you know, a specific medication, dopamine agonists like pramipexole or some other dopamine agonists, that can cause a side effect causing this visual hallucination. But also patients might just experience later on, say 5 years, 10 years after the diagnosis of Parkinson, even though they stop those sort of medication, they might still experience visual hallucination. But these days there are good medication for that, for treating that, if that exists. But it also might be just from the visual processing. It can be from the retina, it can be from the brain, and or it can be just from the side effect of the medication. But again, you know, movement disorder specialists usually do a great job in detecting this and treating this, because these days there are great medications for that. And like you can see, this is an MRI. And here, when you can see this yellow area, this is the area that is the center of visual processing in the back of the eye. And you know, some studies, some fMRI studies show that in Parkinson patients who have visual hallucination, there are some signal abnormality in the back of the eye, meaning that visual processing has some problems in the back of their head, and that's why they experience visual hallucinations. And also there are some recent studies that they show that visual hallucination just might come from the retina problem. And again, a routine eye exam just to assure that retina doesn't have any problem will, you know, will reassure you and your family that there is no retina problem, but it might be just, you know, some physiology of the retina that is impaired because of the lack of dopamine. Um, but again, this area is under investigation at this point, and you know, we'll know more about this in the future. So in conclusion of this talk, so like we discussed, eye and visual problem are very common in Parkinson patients, and caregivers and clinicians, movement disorder specialists, neurologists, and primary care should pay special attention to this area. And a routine annual eye exam is recommended with an optometrist. Optometrists really do a great job in just catching if there is any abnormality or if you need eyeglasses or anything that can improve your vision. They're doing a great job. Dry eye management, they're great. So you can have an optometry exam or a routine, you know, ophthalmology exam. And then if they feel the need that you need to see a neuro-ophthalmologist, then they will give you that referral for more complex problems. And again, this collaboration between optometrists, ophthalmologists, and neuro-ophthalmologists and movement disorder specialists is necessary to ensure that we address these visual problems that can be potentially very disabling in Parkinson patients. And again, this will help to improve quality of life and, you know, potentially improve your function and just daily activity. So that's why it's very important to take care of that. So just let me know if there is any question that I can answer here.
Well, thank you, Dr. Miri. And if you have a question, you can go ahead and unmute yourself and ask it. Or you can type it in the chat box as well.
Can I ask a question?
Yes, go ahead.
Does rosacea of the eyelids have anything to do with dry eye?
No, not really. It's just a kind of, that is a kind of a skin problem. But it is very common in Parkinson patients. But it doesn't really have to do anything with the dry eye. But having that might show that maybe the small glands like near the eyelid also can be affected, and that will increase like kind of inflammation or inflammatory changes around the eyelid. So it happens at the same time sometimes, but not that it's a kind of direct like etiology of dry eye.
Thank you. Can I ask a second question? Is
Sure.
there any problem with cataract lens replacement in Parkinson's patients as opposed to normal patients?
No, there is there is no really known study to say how do they respond to cataract surgery in Parkinson and compared to normal people. I have seen a lot of patients who after cataract surgery still they get double vision, but it's still not known that is it any different in, like, is it like related to Parkinson itself, their double vision, or is it related to the lens? But, you know, sometimes the lens misalignment can cause the double vision. But again, if someone has a visually significant, a severe form of cataract, they should do the surgery, you know. Uh, so, yeah.
Thank you.
Sure.
I don't have a question, but it's more a comment.
Sure, go ahead.
It's related to the neuro problems, the ophthalmological neuro problems related with a type of Alzheimer's. My dad was diagnosed as Alzheimer's, but I believe he was not diagnosed as Parkinson's, but I believe he did have a type of Parkinson's because he had the shuffling gait and mild tremors. We cared for him at home, and we took out the carpet in the hallway so he could more easily get to the bathroom with his shuffling gait. And the wood floor made it easier for him. But then there was a depth perception of the wood floor with the wood baseboard. And so he couldn't, that created a problem with his perception and walking. So we had to then, we put railing up on the hallway so he could hold on, which made a big difference for him getting to the bathroom, even though the depth perception problem was still there. And we finally realized the problem, and we put a different color on the baseboard so he would know the difference from the floor to the wall on the side. But the similarities in the eye problems are there with the neuro problems.
Definitely, that's a great comment. And actually, you're right. And this kind of visual problem actually are also common in Alzheimer's disease, some of this. And also, there might be like an overlap. Your father might have had a Lewy body dementia, which presents first with memory symptoms, but also in addition, some Parkinson symptoms. And probably it was a Lewy body dementia maybe, but you point out to a great the point, that is sometimes if they have a lot of difficulty walking around and a lot of shuffling, it might be just because of the visual perception problem. You might not be able to fix that, but if that's the problem with visual cue and, you know, preparing the appropriate, you know, home environment, you know, adjustment, then you might improve the, you know, walking and the function.
Right.
That's great comment.
Yeah.
Thank you for pointing out.
Okay, thank you. Looks like Annette has a question. Go ahead, Annette.
Hi, my name's Larry. I have a question, doctor. What's the difference if the double vision is side to side versus up and down? What's the significant difference?
Sure. So, you know, things like when we discussed convergence, insufficiency, that's like you will see just side by side double vision. In convergence, because both eyes cannot come together like to the center. So those people will have side by side. And actually, that kind of like side by side is more benign. So Parkinson patient might also have a very mild up and down double vision. But again, that is also, if it is because of ocular misalignment, that's fine. But there is a type of stroke that can happen sudden, and people might experience just up and down double vision. So that's sudden onset double vision, and that they will see the vertical diplopia, which is up and down. And that's something that should be, we should be just aware of. Not to say that Parkinson patient will have that, like more common, no. It might happen in even less than like say 3% of people, but just sorting out side by side versus up and down will tell us where is the problem coming from.
And is that normally corrected by a prism in your glasses? Is that the way that you deal with that?
Yeah, if it is from the from the orbit and from the way that the eyes are aligned, then even if it is up and down or side by side or a little bit of combination that people will see diagonal diplopia, then prism will help with that. And we always give a trial of prism, and sometimes we give a prism, you go home, and then after like a few say days or week you feel not comfortable, or then we'll change it a little bit. It takes time, but in some cases it will help significantly. So that's why we should at least give it a try. In some other people, it might not help, but at least that's an option, just to give it a try.
And I'm sorry, but just one more fast question. You said when you take the carbidopa, it sometimes will help with double vision, but what if it doesn't help? What if it obviously helps relieve your stiffness in your legs, if it doesn't have any effect on the double vision? Is that unusual, or do you think it should work for both at the same time?
Sorry, the last part I didn't note. I didn't. Can you repeat?
You said if you take the carbidopa, it will help, in addition to obviously helping with stiffness in the legs, it should also help with the double vision. But what if it just does the regular thing and helps with the stiffness in the leg, but it doesn't do anything on the double vision? Is that unusual, or is that normal?
No, actually, you know what? In some cases, it doesn't help. What I was saying is that some people with Parkinson's disease experience double vision just intermittently and only when they are wearing off of carbidopa-levodopa. And when they take the medication, they say, oh, the double vision goes away. So I was just telling you the different types. So some people, for example, those with convergence insufficiency or the ocular misalignment, that doesn't get any better with the carbidopa-levodopa. So yes, that's common. Like that doesn't, carbidopa-levodopa
Right, it's just
help everyone.
Thank you for all those excellent answers. Appreciate it very much. Thank you.
Sure, definitely.
Annette, go ahead if you have a question. I know your hand was raised before.
Well, the previous speaker spoke to the double vision. I'm just wondering too, I have a drooping eye and they are going to use, and my double vision happens, I think, because of that, but I never thought of this crease in my head coming from that. And I've had that for a while, but I think I've had Parkinson's mild for a long time. So I'm wondering if that really is part of, if I get the, what do I want to say? The injection in my eye to lift that lid, will that be helping my double vision also? Because I'm getting it because sometimes I have to cover, well, by night, my eyelids well done, and I'm looking out of one eye only, which makes my vision difficult.
I see. So you have droopy eyelids that are getting worse at night. In the morning when you wake up, there is no droopy eyelid, but like toward the end of the day that you're very tired, you get more double vision and droopy eyelid, correct?
Correct.
Yeah. So that actually, for that, there should be another evaluation. Have you heard of a disease called myasthenia gravis? So that's a muscle, a neuromuscular problem that can happen in anyone, not just Parkinson patient, in anyone. So there is a blood test for that to see if you have that or not. And any neurologist can evaluate that. You should ask them and say, I get droopy. That's called myasthenia gravis. And actually, that has nothing to do with Parkinson itself. Okay. And for that, actually, you do not do the injection, because this droopy eyelid happens only at night and then it improves later on. That's just because of the muscle fatigue. And
I also had Bell's palsy, and I wonder if that is doing that also. But you're saying it's not really going to help my double vision, though, is...
Yeah, no, Bell's palsy doesn't do double vision. Bell's palsy is just a weakness of one side of the face, and I can see that. That is probably was a long time ago, not recent.
Right.
So, yeah, so Bell's palsy should not cause double vision. So if you have double vision, we should just investigate some other causes. But again, what you described to me can be just a muscle fatigue problem, which is a neuromuscular problem, myasthenia gravis. And myasthenia gravis can involve like the whole body, can cause shortness of breath and all that. But sometimes it's just affecting the eye. And, you know, people experience just eyelid fatigue toward the end of the day, and a lot of diplopia, a lot of double vision. So, and that has like a separate treatment, a completely different medication, which is called mestinib. But for that, we don't do Botox injection, because when you inject Botox, actually you weaken the muscle that is already weak. So you don't want to do that. And so for that, you just ask a general neurologist and tell them that you are experiencing this, so they can test. There are like different type of tests, blood tests, muscle tests. They do that, and if they confirm that, then there is easy treatment for that.
Thank you very much.
Sure.
And Dr.
The
Miri, do you have,
presentation was excellent.
Sure, definitely. Thank you so much.
we have two additional questions in the chat box. Do you have time?
Yeah, go ahead.
Okay. My double vision gets worse as I get tired of driving or reading. Will prisms help with both near and far focus? And will they work when I am not tired yet?
Yes.
So again, what we discussed here with Annette, right? So sometimes again, when you get tired and when you get double vision toward the end of the day, again, that key question of like droopy eyelid, if that happens again, we should make sure that other reasons like myasthenia gravis is not the cause of that. That's number one, because that caused droopy eyelid and just intermittent double vision, especially when you're focusing too much or when you're driving, just constant, you know, gaze, like looking at somewhere can cause that. Again, first, we should make sure that's not the problem. You should ask your doctor. The second thing is that if it is a fixed kind of ocular misalignment problem, prism can help that. And prism can be prescribed differently for both near and distance. Usually, if people are driving and they really need to like have that double vision corrected, we can prescribe a separate prism for distance and a separate prism for close for computer. Most commonly, people with Parkinson have close, just reading double vision. And in those cases, like we more commonly prescribe prism for near. But again, if distance happens, we can do that as well. And again, we should just make sure there is no other causes like we discussed, myasthenia gravis, because that comes with just tiredness and fatigue.
Thank you. And a question about, I'm not sure how to say it.
Blepharospasm.
Thank you. That's from Karen.
Yeah, I'm wondering, we had a friend with Parkinson's who was in a care facility after an injury. And when I was talking with the staff, they kept saying, she won't open her eyes. She won't open her eyes. It was being perceived as her being obstinate. Could that have been blepharospasm? You know, like she was just not happy where she was, so she wouldn't open her eyes. But now I'm wondering if it was blepharospasm.
I think it is possible. It is possible. In blepharospasm, I mean, you know, atypical Parkinsonism, atypical Parkinson like MSA, PSP, those people actually have eyelid opening apraxia, which is when they close their eyes, they even have difficulty opening. You don't see any twitching around the eye. They just cannot open it. It just doesn't open. And then if they open it with their like finger, then it stays open. So that's also like, you know, a separate problem. It can happen just by itself, or it can happen at the in combination with blepharospasm. Blepharospasm is a kind of, you will see someone is like squeezing the eye. So
that's what they described.
Okay, so in that case, I mean, definitely it can be just blepharospasm for sure.
Because I had never heard of this, and it would help for the people caring for them to know it's not a choice. They cannot open their eyes, right?
Right, definitely. Okay. And actually, again, Botox injection, botulinum toxin injection, there are other type of botulinum toxin that we do. That will help a lot. That will, you know, not after first injection, but say if they inject it every 3 months, you will see after 1 or 2 injections, you will see significantly they can just open their eyes.
Thank you. Thank you so much. This is great.
Sure, definitely.
Thank you so much, Dr. Miri, and for taking a little bit of extra time as well to answer questions. And this is recorded, so I will email you a follow-up with the recording. And thank you so much for joining us today. And we hope to see you again soon.
There's one more question, Casey.
Oh, one more question came in. Okay, this is the very last one. Thank you, Christine. If PD patients have trouble differentiating contrast, why do websites, questionnaires, etc. for them so often publish stuff in light gray on white? This seems to be some sort of default.
Yeah, that's a great comment. Yeah. So yeah, unfortunately, not everyone pay attention to that, and you know that's something that they really should just pay attention to that.
That's probably more appropriately directed toward us, and we appreciate the feedback.
Yes, for sure. Things that make you go, Okay, well, thank you all so much. Have a wonderful afternoon.
And just one more comment. We were talking before we actually started about the lack of neuro-ophthalmologists. It's a real specialty. I put in the chat the link to the North American Neuro-Ophthalmology Society. So if someone is looking for a neuro-ophthalmologist, you can jump on that website. I just looked at it, and with the exception, excuse me, of Children's Hospital here in Pittsburgh, which I imagine they're primarily pediatric, there's only 2 neuro-ophthalmologists listed in the on the website there. So yeah, we need more, I think, right?
Definitely.
Okay, well, thank you, David. I'll also include that link in the follow-up email. I think this is our final goodbye.
Thanks, everybody. Thank you.
Bye. Thank you so much. Goodbye.
Thank you.